Hey, what's up and welcome to world number 7 of Power Up Endo's 90-day Super GP course. In this world, you will have already seen, hopefully, the crown prepared lower molar live case demonstration, which is a super practical case that, again, you should probably come across all the time in your general practice. And in terms of the didactics, in this world, we're going to discuss endodontic radiography. Let's get right into it. Now, I remember very, very clearly when I was a resident being super stressed about this aspect of endodontics because obviously you don't want to have to constantly take retake shots on your patients because they're going to get annoyed that they're getting exposed over and over again, and that's understandable. So it's going to cause the provider and the assistant a lot of stress. But once you learn the technique, it should be second nature and should be a non-issue. Also, you're going to train your dental assistant to perform these working radiographs usually. And so once you get good at it, you can train your dental assistant. They'll have a little bit of a learning curve as well. But once they're trained up, you're on easy street. Now, granted, there's going to be the occasional time where they need your help and you get to come in and be the hero and take a retake that's going to give you the correct and appropriate amount of information. But generally speaking, once the dental assistant gets up to speed, they're oftentimes better at it even than you are, which I tell them occasionally just to puff them up. There's a certain sequence of radiographs that you have to take, or that I would highly recommend you take when you go about performing endo treatment, okay? So you need some preoperative radiographs. That's mandatory. You already know that. You need to take some form of working radiograph, and I'll go over what those are. And obviously, you're going to take your post-op radiograph. So let's get right into those. So in terms of pre-op radiographs, I would highly recommend you take bite wing and periapical films, obviously bite wing for your posterior teeth. The combination of those two is going to give you the amount of information that you need in order to study the case, to know what you're getting into before you get into the case, and also to determine whether you even want to treat this case or send it out, or perhaps even recommend some other form of treatment such as dental extraction or whatever. So it's good to have a bite wing radiograph. It allows you to see the pulp chamber much more clearly and gives you more information. In terms of your periapical films, okay, you want to take obviously at least one. Oftentimes, it's advocated for, especially in academic settings, in terms of formal training, to take a straight shot and to take an angled shot. That is the recommended amount of preoperative radiographs. Do I always take an angled shot? No, not necessarily, because oftentimes I don't find that it's necessarily needed. And so, again, we don't want to expose our patient more than we absolutely have to. But technically speaking, that is what is taught when you're obviously a dental student and then an endo resident. And clearly, this information is vital to make sure that endodontic treatment is appropriate and indicated for this given scenario. And then in terms of your working radiographs, I would recommend you always take a working length film, even though the electronic apex locator is giving you an estimated working length. That is a tool and it's an instrument and it's not perfect. Granted, it's very accurate in the vast majority of the time. There are some things that can cause it to be inaccurate, and you want to trust it, but you want to also verify what the electronic apex locator is telling you in terms of the length of the case. I would also recommend you always take a cone fit radiograph after you've instrumented the case and you've gone ahead and proceeded to the obturation phase of the procedure. And I recommend, as I mentioned to you in the live case demonstrations, taking a wet shot, which is basically a cone fit radiograph where the sealer has already been applied. And the beauty of that is that when you're taking this wet shot or this cone fit radiograph with sealer, there's going to be far less variables that are going to change in terms of how it looks at that point and what the end product on the post-op radiograph is going to be. And I like to know exactly what that post-op radiograph is going to look like, because there are a few things more annoying than taking your post-op radiograph and noticing something's wrong, and then you have to explain to the patient that you have to go in and make an adjustment. Does it happen sometimes? Yes, especially if your cone fit radiograph isn't diagnostically accurate, and what you think is a cone fit and a gutta percha cone that's all the way to the apex actually is a little bit shorter than you really want, or if when you obturate, you get a little bit of extension of the gutta percha past the apex. All those things are situations where you may have to tell your patient, hey, I'm a perfectionist and I want to give you the best possible treatment that I can, and it's going to require me to just quickly get back in there and make a little adjustment. But you don't want to do that, because obviously it's going to cause you to fall behind in the schedule and it will annoy your patient clearly. But a wet shot is great because you're not changing variables nearly as much as when you're taking out the cones after your cone fit, putting your sealer and putting the cones back in. What can happen as well is that when you reseat the cones after your cone fit radiograph, you could get them to bind up inside the root, and therefore the cone won't actually make it to the apex. And you only discover this after you take your post-op radiograph. I want predictable results as to what the post-op radiograph is going to look like, and I think that taking a wet shot is going to give you the highest probability that you're going to have an exact match in terms of what the cone fit radiograph looks like and the post-op radiograph. And then obviously you're going to take your post-op radiograph once your treatment is complete. I will oftentimes walk out of the room at this point and either see another patient or go write up my chart note. There has been a time over my career where the dental assistant gets chatty with the patient and they walk the patient out and they forget to take the post-op radiograph. It can't happen. And then you got to call that patient and ask them to return another day to take your post-op radiograph. So don't obviously let that happen. It's a very simple thing to do. In terms of what you're going to use to take your radiographs during your endodontic procedures, there are lots of little tools and devices to take working radiographs with the rubber dam on, which you're obviously going to do. Okay, most people have DEXIS sensors, right? And so DEXIS will actually give you these items when you purchase your sensors, and these are just handheld platinum digital sensors. They come in a horizontal and a vertical configuration. Generally, you're going to use the vertical configuration for your anteriors and your horizontal configuration for your posteriors. And clearly your patient is going to hold this device with the rubber dam on, and you're going to go ahead and aim the tube and take your radiograph. Do not skip steps with this. You need the diagnostic information at each step in the endodontic procedure for you to perform your best work. Also, I recommend that you leave the lead apron on the patient for the entirety of the procedure. So we actually place it on our patient before we put the rubber dam on their tooth, and we leave it on throughout the procedure. I've seen providers just lower it after they take their radiograph and then bring it up, but you don't want to forget to cover your patient with the lead apron. And so I find that oftentimes just leaving it on for the 30 minutes, 45 minutes of the procedure is one less thing to think about. Also, some patients find it actually comforting to have that weighted blanket, if you will, on them for the endodontic procedure. I'd recommend you just leave it on your patient and just don't forget to put it on initially. And you want to take your time with the radiographs. I know it can get frustrated, especially if you've taken a retake of a radiograph and you're still not happy with the information that it's telling you. But you don't want to settle for bad radiographs, because you're going to encounter a situation where you think the case is going great, and then you take off the rubber dam, you take your post-op radiograph, and it looks way off from what you thought it was going to look like. And you could have easily made adjustments while the patient was still reclined with the rubber dam on and their tooth was open, and it creates an awkward conversation when, again, like I spoke before, about having to tell the patient that you have to go back in and make an adjustment. Also, don't be concerned that the sealer that you're going to be using is going to set on you. It's going to be much easier to make an adjustment immediately after you've obturated the case by removing the cones and then re-obturating than it is bringing the patient back in a week's time to make an adjustment, because that sealer will set in about 24 hours. Also, a student of mine actually was mentioning that he was concerned that when you remove a cone and need to get a new cone to get it to fit properly during your obturation, that he was concerned that the sealer could easily set and therefore create a problem. Don't worry about that. You have many, many, many hours before the sealer is going to set, and so little adjustments with the sealer in the canals is not going to make a difference. And remember, when you're taking your radiograph, so whoever's taking that radiograph, when they go ahead and bring the instruments, like the sensor holders, into the patient's mouth, you're likely to get saliva on your fingers. Remember, you want to treat the entire procedure like a microbial culture. So I would highly recommend that whoever's taking the radiographs assume that they're going to get their hands dirty, if you will, and have them swap out gloves. Like I said, once your dental assistant gets good at this, make sure that he or she removes the gloves and then puts a new pair of gloves on before you continue with your endodontic procedure. A root canal system, when you're working on it, is like a microbial culture. So that's why I put that petri dish image there. I want you to really burn that in and remember that you're dealing with a system that is very prone to cross-contamination and therefore negating all the nice work you're doing and working so hard to do when you're performing your endodontic treatment. Predictable results will breed confidence. So once you get these systems down and you incorporate them into your practice and you have results that are predictable over and over again, you're going to feel very confident in the services that you're providing, and it will come with time. Obviously, initially you're going to be a little bit anxious about each of these steps, but it will become second nature, and it will be no different than performing a class 2 restoration. Also, take the time and train your assistants. If you train them properly, as you already know, they're going to do a lot of the work that's stressing you out, and it's going to allow you to kind of be on autopilot and just enjoy the procedure, as opposed to being concerned that your assistant is not really as helpful as you would like them to be. And there you have it. That's really all there is to endodontic radiography. There's more in this world that's going to give you even more confidence, but it's not overly complicated. And again, I'm only giving you exactly what you need to know to have predictable, successful endodontic treatments performed in your practice. I'll see you in the next lesson.